having a panel with the same faculty. Dr. P.N. Jain would not be able to join because he had some commitments. So just 4 of us. I will be moderating as well as I will be on the panel too. Okay, so interventions in palliative care. So now what has happened over a decade or so is that now in India, or rather even in the Western world, so if you see palliative care, it's not the new thing actually. Now Hippocrates has always definite means, I think in his oath he himself said that you have to care of the patient more than giving the active therapy. So palliative care started from that time. So it's not that it's a new thing, but just we have started a curriculum or an academic activities or an MD program in palliative medicine a decade ago. Now there is a lot into these things because interventions, whether it is the authority of certain specialties or the certain specialized groups, no one knows because it is really a gray zone. So we will be discussing more into that about these things. So first thing is that why interventions are needed in palliative care. So I would like to ask this question to Dr. Sada. So would you like to take this question? So why we need interventions in palliative care? Just press it hard, yeah. It will come.
Interventions are useful in palliative care primarily to reduce the opioid load that palliative care patients will be on. It also gives you a good opportunity to treat their incident pain, which sometimes you may not, incidental pain rather, which you may not be able to treat with any of your oral or IV systemic medication. It also gives a patient an immediate sense of well-being. So as soon as you do a procedure or do a block and do a successful block, and the kind of relief that the patient has, sometimes you may not be able to get it with all your oral or IV medication. But yeah, these are essentially why we need to do.
Yeah, yes, true, rightly said, because so now we are doing interventional pain procedures mainly to get down the pain. So as an adjuvant towards all other modalities of our palliative care armamentarium. So this is one of the armamentarium which I suppose and I think that a palliative care physician should also be very well versed with. And it's not that if such a procedure comes and he's not an expertise to do those procedures. And I think they should be doing that, right? So when to do this interventions? So Dr. Shiv, I think he has already included that in his talk, but still I would like to ask you to highlight because there is a lot of dilemma here. See now, as he told in his talk, right? He said, when the patient is diagnosed and if he is already on some pharmacological management, what if you give a shot of injection so the patient will give that quick sense of well-being? So now, is it that the right way, or we need to just wait for the patients going on his chemotherapy or surgical therapy and still he is in pain, and then we should take a chance of giving this when he's already into a stage 4 cancer?
The question, the answer of this, when to go for interventions for these cancer patients. Definitely, communicating with the patients, understanding the patient's condition. But apart from that, I think discussion with the oncologist is also very important.
Yes.
Because the patient may be receiving some treatment. Radiotherapy itself, like what we do usually we are doing at our place. We are discussing the patient's condition first with the oncologist. First with the patient, telling about the pros and cons of these procedures. And once the patient says, okay, yes, we can go for this, then we discuss with the oncologist also, just to make sure we can safely go for this. Like I told in my previous, in my presentation, that for radiotherapy, we are not doing concurrent interventions. We are delaying the interventions if the patient is on radiotherapy, usually 10 days to 2 weeks. This is as per the discussion with that.
Yes, rightly said, because I always believe in an interdisciplinary approach. So discussing these things with your colleagues, the medical oncology or the radiation oncology or the surgical oncology will really helps again to prognosticate, because even the prognostication plays a very important role. That is what I feel. So what do you think about this prognostication issues? Do you think this prognostication plays a real important role when we are deciding to offer an intervention to this group of patients?
Yes, because the patient's actually functional status gets improved after getting any interventions, like the patient with the celiac plexus neurolysis in upper GI malignancy. Usually we see a very favorable outcome and very favorable outcome in terms of patient survival also. The patient's life expectancy also gets prolonged after doing all these interventions. It has been proven in different studies. So I mean, as and when necessary, whether it doesn't matter whether it is in the early stage of treatment or disease trajectory or late. Whenever the patients is, every patient individualized treatment approach has to be given for the benefit of that patient.
So do you think that suppose if the patient is having a benefit with pharmacological agents, do you still go ahead with this interventional procedures?
Okay. If the patient's pain is controlled with the pharmacological management, like 100%, there is nothing 100%.
Yeah,
the patient pain 100%. Is manageable with the opioids, I don't go for interventions. But definitely we give enough information so that the patients get prepared in future. Okay, if I have more pain, because the patient will have metastasis, definitely he will have more pain, then the patient has some choice of discussing about the intervention.
So because that is what the problem we face. So now what happens is that most of the times the patients do come to us in an advanced phase, and the patient is opioid naive, he has not even been given a trial of opioids. So do you think that such group of patients, because in our setup what happens, they come from far away places, 2,000 3,000 kilometers away, and they are not going to come back to us. So do you think that this will be an appropriate timing, because these opioid naive, no opioids have been given, just Narcodol, Tramadol, Calpol-T has been offered by our oncological colleagues, and they come to us in severe pain, and now they say that we are going back and we may not be coming back to you. So do you think we should offer an intervention, or we just start them with opioids and again just see whether that is really helping them or not?
So I can correlate your question with two things. Number one, I mean, if the patient is coming from very far distance, like 2,000 kilometers or maybe somewhere like that, and Dr. Sra also showed some of the, one publications in which he showed like maybe favorable outcome after doing so many interventions. If you see the interventions, these are lumbar facet joint injections, epidural, spinal injections. Actually giving medicine, not non-opioids medicine as well as opioids for these kind of pain syndrome will not help the patients much. Rather than giving interventions and having more prolonged pain relief will give more benefit to the patients. Patient don't have to take unnecessary side effect of medicine also. So I believe like,
so ultimately it is up to the patient. You have to just offer the menu to the patient.
Right.
These are the offerings. These are the possible things, a pharmacological intervention, and this is an interventional intervention which we will be doing.
Yes, and the most important thing is the clinical diagnosis of that pain syndrome is very important. If you think, okay, this pain can be cured with interventions, why not to go for that?
So that is what, again, to going about this point, because if you see, cancer pain is very multifactorial. So there won't be any proper dermatochemical distribution as you may be getting. Like, for CA pancreas you may have, but if the CA pancreas is also metastasizing to certain other organs, or for example, if it is going to bones and all, then again you may have that component of pain also. So again, it depends. So he rightly said, you have to really diagnose the cancer pain syndrome, and you have to see whether this is really amendable to that intervention. Otherwise, what will happen? You give a celiac plexus block and you will still have a backache. The patient will be unhappy with you, right? So this is what is very important. Timing, actually diagnosing which component of I can say the pain syndrome the patient is falling into. So these things you have to take into account. And yes, you rightly said that it really doesn't matter whether the patient is opioid naive or not, because this publication which Dr. Sada had already shown, has shown that it doesn't matter, because if you're just giving an intervention and if the patient is accepting it, so ultimately patient acceptance is very important. And if he's accepting it, yes, you can go ahead with the intervention, then you can make him off the opioids. Don't start the opioids, because opioids do carry the side effects, especially the constipation, which is very discomforting to the patients.
And
So, yes,
one
Avinash.
more thing I want to add, it is very difficult to get morphine in far places.
Yes, yes.
So it is always better to do intervention early so that patient will
So,
easily manageable. On
I was
treatment
coming to that. I was coming to that only. So that is what is another aspect in our country, because in our country the thing is that the distribution of the population is 70% is in our rural areas and 30% is in urban areas. Even in 30% urban areas, the opioid availability is not there. So offer this intervention which gives them a good amount of pain relief for a good amount of duration, 3 months, sometimes goes for 6 months. And again, if you go back to the cancer itself, and if you see, for example, lung cancers, now because of the immunotherapies and because of the monoclonal antibodies, the life expectancy or the disease-free survival or the overall survival, if you see, has drastically improved up to 60 months. So though the intervention may not last for 60 months, but still you can give him a good period of a pain-free interval around 6 months, which really helps them to cope up with their life, and good rehabilitative programs they can do with all these pain-free durations. So that is what is, and opioids are definitely not available at most of the places. And if you send them with opioids, again, it becomes a big hassle. And even supply, though we have a pallium centers all over India, they are not easily approachable centers to most of the patients, because still, again, they are almost 300 kilometers, 400 kilometers away. And it's cumbersome and too logistical. It's challenging logistically for the patients to go to those places, because morphine is not given just like that, even if you give a referral letter, because they need to see the patient, because we need to understand whether there is opioid pilferage is not happening or opioid diversions are not happening because of this narcotic issues. So coming to Avinash, to you, the question, so who should be doing these interventions? So now, see, the pain medicine itself has not developed as a specialty compared to palliative medicine has developed itself as a specialty. So now there are many stakeholders to it. So what do you suggest? What do you think?
So I said there is two questions: who should do and who can do.
Yeah.
So first I come to who should do. So a person who is trained enough in any teaching institute, like in Nether, I say that they should allow to do all the intervention, because there are different domain of intervention. Like suppose sir said kyphoplasty. So orthopedics said that kyphoplasty is their domain. Like nerve block and epidural block is the domain of anesthetist. So either the procedure should allow to do by the respective branch. Like orthopedic is supposed to do kyphoplasty, and a person who is trained enough is supposed to do kyphoplasty. And in palliative medicine courses, I feel that especially cancer related, all the intervention should include it, and they are supposed to do this.
So you think a palliative physician should be trained? Yes, because if you see our NMC website, the National Medical Commission website, and the syllabus of our palliative medicine, yes, we have inculcated this in the syllabus. So if you go back and check it, that the training should be, optimum training should be given to those trainees of palliative medicine, including fluoroscopy and ultrasound.
One more
But
thing,
the procedures, which procedures should be done, have not been mentioned.
one more thing I want to add, that even at present there is a lot of vacuum in palliative medicine.
Yes, yes.
So there, till this vacuum supposed to fill, there should be small courses for like anesthetic, for doing kyphoplasty in cancer patient. So they are supposed allowed to do, because medical legal challenges are there. So what is your take on that?
So see, that's what I told you initially. Only I told you, because there are many stakeholders in this particular branch of pain. And now you see, now if you ask, now where we were trained, now myself, Sada and Shiv, we were trained in Singapore, right? Now there are vertebroplasties or cementoplasties were done by orthopedic surgeons. So I asked Tan, our director of pain management centers, Tan, we are not allowing us to do kyphoplasty and vertebroplasty. We are coming here for a training for 1 year. So now he says that vertebroplasty or kyphoplasty is a stabilization procedure. And according to their law, a stabilization is done by an orthopedician. So you are not supposed to. So that clear-cut law is there. But if you come back to our country, so there is no such law anywhere existing. To say that yes, you are an anesthesiologist, so you have to do these things. Okay, you are a neurologist, you are supposed to do these things. If you ask that way, a neurologist manages trigeminal neuralgia. So for that sake, orthopedician manages all the spine procedures. They do surgeries and all. So there is no proper stakeholder of these things. So coming to your question, right? The medical legal, right? So now our good friend knows that, right? So if you are trained enough, right? That's what the certification you got, right? So if you are trained enough in any particular procedure, right? So, but they have not mentioned any duration, I don't know. But if you're trained enough and you have been doing these procedures, since there are no stakeholders of that particular of this particular specialty, I think you can be allowed.
I will say, I will add a further thing. If you are able to manage the complication associated with the procedure, definitely you can go. Any registered medical practitioner who can, like suppose medical oncologists, they are doing a simple lumbar puncture. If they are able to manage the side effect or the complication associated with lumbar puncture, I mean, they can do. Yes. So that's what actually, it's a.
So now just to add to this point, now if you see just out of the context, because if you see a cardiologist doing interventional cardiology procedure, especially putting a PTC, right, the stent they're putting, they always keep a cardiac surgeon standby. So the same thing might be applying to our advanced procedures if you are doing now. For example, if you are doing intrathecal, it is not necessary that you need a surgeon to create a pocket. That's a very small thing, but certain spine interventions like discectomies, right? I think we should. What is your take on that? I think we are just going off the way from the cancers.
Yes, yes. I think we used to do endoscopic spine surgery, and then the important thing is that, as I told, number one, able to manage complication associated with that, how much competent you are, how much training you have taken for that procedure, and if you have a good communication with the surgical colleague who can give you cover during if anything apart from the standard, if any deviation happens, who can support you? Definitely, yes.
Yes, so totally agree. So who will be doing these interventions? So as rightly shared by Avinash also, and by me, by Dr. Shiv. Now, if you're properly trained, yes, because MD palliative medicine program syllabus has inculcated this thing that the person who is coming for an MD program should be trained for these intervention procedures. So definitely, I think palliative medicine specialist can do these procedures. I think there is no doubt about that. And I think we will wrap up with this. I think there is no further discussion about this. So I would like to thank each and every one of you, as well as the organizers and my colleague faculties, Dr. Shiv, Dr. Sada, Dr. Avinash, as well as all the participants and the delegates who have attended in physical, as well as those who have attended online. I would like to thank everyone, as well as a special thanks to Dr. Jain sir, who in spite of having his some commitments, would able to make it online. Thank you everyone.